invite the two speakers to sit here for the Q&A questions. You can ask the microphone now. Please state your name and institution.
Renato Fanchin from France. Nice presentations. Thank you. I had a question for Carlo. You talked about endpoints, the need for good endpoints, and you spent much of the presentation showing us the number of eggs at the end of the stimulation. What do you think about the origin of the eggs? About is this follicle size matters? It's the same thing to do the retrieval on day 8 or day 12 or day 6. So I would like to know what your opinion about the criteria of triggering the ovulation and going to harvest good eggs. In my experience, I have almost all retrievals I do. I have follicles just there at 12 millimeters, 12, 13 millimeters. What I do is I aspirate these follicles. I cannot resist, okay? But I was trained to know that the competent eggs come from over 16 millimeter follicles. And at the end of the day, I give the result for the patient, and she has 15 eggs or 12 eggs. And it doesn't matter exactly the number of mature follicles she had. And just to, you know what we discussed about that. So the fort was conceived to be robust for that. So we compare follicles to follicles. And the response to FSH is the follicles is addressed to the FSH is addressed to follicles, and we have some follicles that reach maturity. So the eggs should be better in these cases. So the effectiveness of the treatment would be different. So what do you think about the criteria for triggering the ovulation? And I think this question should be also interesting for you with your random start stimulation, because in this case, we know that the size discrepancies of follicles are more important too. So I would like you to have your both opinion on that.
Renato, thank you. Obviously, your questions are open doors, and so we could finish tomorrow, but I will try to. It is something intriguing because, at least at my knowledge, there is no study that gave the possibility, I don't think it's by methodological point of view possible, to clearly understand what is the oocyte tracking, which kind of oocyte gave blastocysts, because obviously you mix all the follicular fluid in the dead space, and it's difficult to do like this. But what I think, I like, but this is my personal way to work, I cannot prove it's better, I like low starting, slow cooking sometimes. Low, I mean 225, 150, even because there are people starting from higher doses. And I was educated by senior embryologists to the concept of cytoplasmic maturity, because before ICSI, or at the beginning of ICSI, they had a look to cytoplasmic aspect, presence of yellow, presence of, I can say more, the density of cytoplasm. And they always told me, take 1-2 additional day, because sometimes cytoplasmic maturation, because even if you have 12 millimeters follicle and you trigger, you can have nuclear maturation, you can have an M2. But it doesn't mean that the cytoplasm is ready for sustaining first steps of pregnancy, whatever. So if the question is, what is the best timing for triggering, following the dominant cohort, I prefer to have at least 10 days stimulation because there are some studies, some trials that trigger even if in 7 days of stimulation follicles are ready. I say in this case, I prefer to wait 9, 10 days, even if follicles reach 20 millimeters, because I have this idea of cytoplasmic maturation. But I cannot prove that is different. But there is another question, and it's also for Antonio, obviously, is when we have advanced maternal age patients, the anti-Mullerian hormone is very low, according to Vine. And so follicles are not protected against FSH. There is no modulation. So it's classical that at the beginning of the menstrual cycle, you have dominant follicles overcome. But even if you see the patient in the previous luteal phase, you can see the dominant follicles 10 millimeters soon after ovulation. So the selection of the dominant follicle is faster. And so at the beginning of the cycle, when we start stimulation, we have 3 follicles, 11 millimeters, estradiol 200, and we have a second cohort of small follicles, very small. And so you start stimulation in 7 days, the first cohort is ready. And what do? We say, this is elderly patient, she can ovulate, we have to trigger before. And then we discover that they have no pregnancy. Probably it is related that in the past we focused everything on larger follicles, but probably this larger follicle, despite started to grow in a previous cycle, had the right environment for cytoplasmic maturation at the beginning of the cycle. So I agree with you, continuous stimulation is nice, and I like to, but I think that the best follicles are the one that you start to stimulate when they are between 2 and 9, and they had at least 10 days of gonadotropins before triggering. This is my feeling, but...
Use the microphone for...
But do you agree that the number of oocytes retrieved is not a very good endpoint? Because sometimes you are retrieving eggs from not prepared follicles. So it's not a good marker of the response to gonadotropins. Because if you retrieve eggs from 12 millimeter follicles, your treatment didn't work, but you had the egg. So I'm just...
I agree with you.
Sharing with you this remark about FOI, because FOI is using the number of eggs, and the eggs come sometimes from small follicles. So this is not maybe a perfect marker of the response to stimulation.
But one thing is to say is not a perfect marker. One thing is to say that is not a good marker. Let me tell you why. Because what you are saying, and I agree, the quantity of eggs, yes, but if you have bad eggs, it doesn't make any difference. So obviously there are specific cases where bad eggs are expected, but in a standard treatment, there is a linear regression, which is very clear. We also have to have a look to the data. So in standard condition, starting from day 2 or in luteal phase where follicles are quite aligned and all follicles had a similar history, probably is a good indicator. Obviously, FOI is a good indicator as KPI for understanding if you are working properly, because if in 1 month in your unit you have less than 30% of FOI, it means that the aspiration system or the triggering system don't work. The only problem of FORT, I love FORT, but the only problem of FORT is let's move to our clinical practice. You see the patient, and she's ready. So let's go on Tuesday, let's go. Do you have the possibility of having fellows or people studying FORT for 10 minutes at any monitoring? That's the only problem of FORT.
Antonio.
Yeah. So it's a very relevant question. Let's pose it this way. So the question is, the way I understand it, are oocytes coming from different sized follicles? Do they have the same potential? So that is the more or less the concept. Okay, so, and as Carlos said, you know, once we do trigger and collect from a multifollicular cycle, you know, it's difficult to tell, you know, which oocyte comes from which follicle. It's like, you know, it's in the lumen. But anyway, so there's one study we know from, I think the first author was Micah Hill. The larger the follicle, the more likely we are to get a major egg. The smaller it is, we're less likely, but we can still get, I know major eggs coming from follicles even less than 10. It happens in the egg. Yeah. And we also know, I think it's also a fact, an IVM oocyte is not the same as an in vivo matured oocyte. I mean, we showed years ago, like they are more likely to be unemployed, etc. So now, whatever we say, it's all our, you know, opinions, because nobody will be able to say that's absolutely the case. So the way I think is, right, so it is, I also aspirate all the follicles, because once you trigger, I mean, they are triggered anyways, so even if it has a lower chance, it doesn't make sense to leave it behind. Whatever I get it, I get it. Then, I think one way to answer this question, which we recently published, it's in Ultrasound in Obstetrics and Gynecology. I mean, it's a good journal, but not the mainstream in fertility. What we did is, as you know, as the age increases, as the reserve decreases, the patient is more likely to ovulate earlier. Their cycles get shorter, they ovulate at even smaller follicular sizes. So what we did is, it's a retrospective study. We compared what was the chance of getting a major oocyte, what was the chance that it would turn into a euploid blastocyst, and what was the chance of that euploid blastocyst reaching live birth in cycles where there was only one follicle growing, so we exactly know where the egg came from, and we triggered them at different sizes. Our practice changed over time for older patients. With one follicle, we started triggering gradually at like 14 millimeters, 13 millimeters. So we broke them into 3 groups, less than 14 at the time of trigger, 14 to 17, and 17 or more. The numbers are small, but the results seem to be similar. The probability of finding an oocyte, the oocyte developing into a euploid blast, and if you transfer it, but transfer result is really, the numbers are so small, it looks similar. So yes, there is some doubt, but I think as long as it's in vivo matured, probably the size of the follicle doesn't matter that much, because the way we measure it is so approximate. It's not a perfect sphere. It's something, amorphous. So we take, some people take 2 diameters, some people take 3 diameters. So probably it's not a great marker.
Can I?
Yeah.
Okay, so a question for both of you. You both said that probably the rate of aneuploidy in embryos and in oocytes is not depending on the gonadotrophin that you used. Well, I'm not sure about this. I mean, we have no studies, but I'm not sure about this because, first of all, we have published in Human Reproduction an article in which, by the use of machine learning, we have demonstrated that embryo euploidy, blastocyst euploidy, of course, is strongly dependent on female age, which remains the most important variable, but still it may vary according to the body weight of woman, to smoking status, male age, and many other variables. You said that you can retrieve M2, mature oocytes, from small follicles. So what happens when we give gonadotrophins to small follicles? Follicle is growing, is maturing, and you know that oocyte has a strong junction through gap junctions with granulosa cells. You showed that when you give gonadotrophins, granulosa cells respond differently to gonadotrophins. Are we sure? Are we sure cannot change their quality when we give different gonadotrophins? Probably the point here is that we are lacking studies. I mean, you both showed a retrospective and cross-sectional study. The perfect study should be randomized by the same women who receive for one cycle, I don't know, one drug, and in the successive cycle, another drug, and then you test and you compare the euploidy rate.
Yes, yes, of course.
Yes,
And
please,
then there's
Monica.
a question
Yeah.
from the audience.
My comment is indeed to mix, to merge what both of you are saying, okay? In the experiment you have done with the Ubaldi group, you have been looking at the euploidy, okay? But who says that indeed the euploidy rate can be strongly influenced by gonotrophins? In this case, you choose an endpoint that is strongly indeed affected by age, okay? And perhaps age is higher impacting the euploidy rate instead of other factors of gonotrophins. I tend to agree with Antonio when he said, indeed, the gonotrophins are changing the granulosa cells, and the age is one of those evidence that indeed there is a difference when you use different gonotrophins. And it's the same because there are other experiments that showed that also granulosa cells are reacting differently, activating differently the same pathways or even activating different pathways. So I think that we should not come to a conclusion if we are not sure that we have the correct tools to measure the conclusion that we want to reach. So before really stating something, I think we need to also identify, and it's not there, what are the biomarkers to speak about oocyte quality, and so the impact on the embryo quality.
I fully agree because at the beginning of testing this hypothesis, I was convinced that a difference in a new product was there. Why? Because if we see that the LH decides how many granulosa cells have to survive, so the oocyte had so many fold increase in the volume in the last weeks, and so the junctions, the tight junctions between granulosa cells and whatever, everything. And what does it mean when we talk about cytoplasmic maturation? It means cytoskeleton, it means Golgi, it means mitochondrial activity, and everything is related to meiotic spindle. So my expectation, and also I don't know if you were involved, but I read a paper 15 years ago by Santi Monet at that time, that he published that he found a difference in aneuploidies. At the time it was fish analysis, or among different gonotrophins. So at the moment, when we say yes or no, it's just consistent with the literature we have. Because we don't have to forget that we have a picture of the trophoectoderm on that moment. We don't know what happens later. So we cannot conclude. I agree, I perfectly agree with you. What I can say now is that there are some phenomena that when are relevant, everyone has experience in basic science knows that is a phenomenon there, you saw the phenomenon soon. So there are some other conditions where you need huge sample size, because I'm sure that the gonotrophins have an impact on aneuploidies, but probably there are so many confounders and variables in this that probably this effect should require probably thousands of observations. But the history is open, I agree.
So, again, I mean, relevant question. So I, respectfully disagree for the reason, regardless of the mechanism, let's say if the currently available gonadotrophins on the market, whatever they are, I mean, HMG, recombinant FSH, recombinant FSH and LH combination. So whatever the mechanism, if they were producing oocytes of different quality, it would show on the live birth rate somehow, right, to some extent. And until today, the number of RCTs at the licensing and the other things, I mean, with all their advantages and disadvantages, So do not suggest a perceivable difference. Right? So whatever is happening in between, at the end, either somehow should be balanced or so. So academically, we can discuss everything in more detail. There may be differences, right? So, but statistics, science is all about approximation. So currently, yeah, they work differently somehow. We know recombinant, say, produces more oocytes than HMG, but at the end, the oocytes, I think, overall seem to provide similar live birth rates. So that's what the currently available data suggests. And it's not a small sample.
Thank you, Boris. And your answer is very logical. But please keep in mind that all the trials we have are limited to the live birth after the first embryo transfer. The euploidy rate, you will see the effect of different euploidy rate in the number of euploid blastocysts. So you should look to the cumulative live birth rate.
So there is a limitation, okay? So everything will be always limited. But so far, correct me if I'm wrong, I think the last time I checked it, the number of RCTs comparing different gonadotrophins overall included more than 8,000 patients, right? So even if it is limited to the first transfer, you would see some difference, right? And the ideal study that you mentioned, which is the ideal, so stimulate the same person with different gonadotrophins in a short time, see what happens. It is probably impossible to do it.
Okay,
So,
there's
but,
a...
let me tell you, no.
Okay, no, because there's a question from the audience.
She's waiting for a long time, so please.
Please.
Hello, I'm Dr. Dawson from Hamburg, Germany. I have a question about the timing of the administration of LH, because you've just told us that the LH is most important in the later stage of maturation. So I was wondering, if I'm using a long-acting FSH, when do I have to administer LH, or do I have it at all? And what would you suggest to do it at what time? And also, I mean, if we use both combined FSH and LH, what time do you think we should start?
Thank you very much for this question. I had no time to go deeper inside in this because but LH is an incredible molecule because LH is not the driver, but is the smooth selector and is able to select and increase quality. It works at two levels. The first level is inducing androgens in TICA cells. And this induction of androgens is a continuous process. You know that follicles do not born with TICA. TICA is acquired during folliculogenesis, but when TICA is there, the androgens production is continuous. And what is important is the balance among androgens. Delta 4 and delta 5 have to have a specific balance. If this balance is good, the androgens induce the FSH receptors in granulosa cells. So at school, we learn that the strongest follicles is the follicle expressing more FSH receptor. But the follicle expressing more FSH receptor is the one with the best androgen milieu. And the one with the best androgen milieu is the one that had the best exposure to LH and the best pulsatility of GnRH at the beginning. This is clear. So, when you give LH since the beginning, you are pushing the androgen system. And so, if the androgen system is deficient, meaning an advanced maternal age, you can probably optimize even recruitment. But in the vast majority of women, the androgen milieu is sufficient. When the follicles overcome 8-9 millimeters, they start to express LH receptors also in granulosa cells. The role of LH in granulosa cells is totally different. At that moment, the concentration of FSH receptors decreases and the concentrations of LH receptors in granulosa increases. You can sustain folliculogenesis only with LH if the follicles are above 10 millimeters. In granulosa cells, androgens are not relevant, are not produced so much. So the LH at that side is important for supporting FSH, supporting paracrine activity, protecting follicles against. So what I suggest is to start always LH since the day one. Because for two reasons. Why? One is simple compliance. Why should we ask patients to change gonadotrophins during stimulation? So at the concentration we give LH, 150, even 225, even more, there is no risk of creating damage in the follicles. The ceiling effect of LH is above 800 international unit. So the system can take what it needs. So if you have a patient above 35, above 38, if the androgens are not sufficient, you optimize the androgen milieu. If a polymorphism of FSH or LH receptor is there, you can counteract by this LH activity. And when the follicles will overcome 10, 12 millimeters, the same LH will work in optimizing quality. So I suggest to give LH to all patients above 35, 36 years of age.
And what was the minimum level amount that you would give LH on top? I mean, if we would do a long-acting FSH and we want to add LH on it, what's the minimum amount of
Probably
LH?
is the moment on day 5 when you start, or day 6 when you start. You can even consider to give it before, but you lose the compliance typical of this kind of preparation, because you choose this preparation because you want to give one injection for 5 days. Dosage of LH?
Sorry?
No, she asked if she gives the long-acting FSH,
No.
when to start. No.
The question, I mean, the
I
question was, would we have an...
I cannot. Can you speak, because I don't see you and I
understand.
take
I'm
some
sorry.
keywords. No, it's
I mean,
okay, it's okay.
The question was if I would want to use a long-acting FSH.
Yes.
Sometimes the women with a poor outcome do react better with that. And I want to add LH on top because I want to do something for the androgens, yeah? That was the question. When do I start with it? You answered that already. But what minimum amount of LH do I have to give it? I mean, I can also give Pergoveris, of course, yeah,
Okay.
that's, I know, but
I think that ideal is 150,
yeah, all right.
but there is no dose finding studies in this setting.
Yeah.
in this
All right.
Okay,
patient.
thank you. I think we should dedicate some time to the question from the online audience now.
Quickly,
Okay. Yes, we have just a couple of minutes.
Okay, so the first one is in women aged more than 35 years, what is the best gonadotropins protocol you use in the light of new evidence?
I think it's association of FSH and recombinant.
Can you say it on
The association of
microphone?
FSH and recombinant LH, I think, is the most effective.
Okay. Right, second.
Okay.
We have two
Okay,
more.
there are a lot of congratulations, but also a question. The day you start D2 stimulation, the large follicle from previous cycle disrupt the response to gonadotrophins. How do you manage this situation in your own practice?
I mean, in the second talk, I'll show cases of these things. So basically, we've published years ago, if that's a patient with a decreased reserve, now I wouldn't even ruin that follicle. I would give an agonist trigger, collect that one, and then continue stimulating the other ones. That's one option you can do. I mean, or you can just leave it alone. The smaller ones can start growing. That one will ovulate in due course and wouldn't affect the other ones. So based on choice. I mean, if she's good reserve, I wouldn't do a collection for just that one follicle. I would ignore it. If she's a decreased reserve patient, I would collect it and continue stimulating.
Thank you. The last one. What can we say about choice of gonadotrophins in hypo patients? Does recombinant LH change results?
Yes, this is a question for Antonio, but no, but obviously change results. But we have many cases. I manage a lot of patients with endocrine diseases, and sometimes clinicians, even with some experience in reproductive medicine, think that if it is an hypo, I give both gonadotrophins, I give FSH, recombinant LH, and the follicle moves. No, because if we have a lot of cases, for instance, very low androgens levels, Addison disease, even long-term hypothalamic amenorrhea, where the androgens production follicle is very, very small, because at the beginning of hypothalamic amenorrhea, you still have a lot of follicles, and the AMH is still normal, and even LH is normal, because what has been lost is pulsatility for selection of dominant follicle. And so there are even the risk of confounding this patient with PCOS, because you see a lot of follicles. But if you stimulate, you are not sure that these follicles will have appropriate response. And when the follicles are very, very small, the risk of not response is higher. Why? Because there are no androgens inside. And so you need to stimulate, probably you need to give LH before, or you give to stimulate many times, because the cycle of folliculogenesis is 90 days, 100 days, so you need a lot of time, because when you are pushing the system with FSH and LH, you are working of preantral or very early antral follicles. Sometimes you need 90 days stimulation of androgen exposure for making FSH receptor expressed and making the follicle grow. So hypo, yes, FSH and recombinant LH, but long-term hypo, patients with adrenal gland disease, very low androgens, or hypothalamic amenorrhea, sometimes they don't have appropriate response even to FSH and recombinant LH.
I agree in the sense, before recombinant LH was available, HMG was the choice. In the ovulation induction setting, not in the IVF setting, but in the ovulation induction setting, I'm aware of one Canadian study comparing recombinant FSH plus recombinant LH versus HMG. I think it was retrospective. They claim better results with recombinant combination compared to HMG. So if the patient is not that complicated, requiring, advanced treatment, and if it is available, the recombinant combination, based on the limited evidence, seems better than HMG.
Well, thank you both. Now we have to conclude, so thanks to our two speakers, Antonio and Baris.